Good afternoon, ladies and gentlemen. It's my pleasure to introduce you to this session, which is Management of CIEDs with New Remote Monitoring Features from Standard of Care to Artificial Intelligence. It's the evolution of the field. It's my pleasure to introduce my colleagues, Dr. Suneet Mittal, longtime collaborator in cardiac electrophysiology from New Jersey, Arnaud Rosier, longtime collaborator in this field, now CEO of Implicity. And I am Dr. Niraj Varma from the Cleveland Clinic, Ohio. Firstly, may I ask you to scan the QR code just now so that you can send questions to us, which we will address either at the end of the talks or at the end of this session. So please scan those just now before we proceed further. And for those who missed the QR code, it'll come up at the end of each talk. So I'd like to begin with some introductory comments. And this is a cartoon depicting the standard of care just now. And on the right-hand side, you see conventional follow-up. For ICDs, it's every 3 months. It could be in-person or remote. We've gone to remote monitoring. What we've noticed is that this is a large burden of activity. At-risk patients are often discovered late because they come at 3-month intervals or even later if they miss their intervals. And many of these calendar-based checks are non-actionable. They don't lead to any clinical change. So this is really a lot of work that is conducted for very little gain. But that is the standard of care that we're operating in just now. What the pandemic taught us was that we couldn't bring patients in every 3 months. We couldn't maintain the staff even to conduct remote follow-ups every 3 months. We had very constrained resources. So what we did was begin to rely on automatic remote monitoring when available, continuous monitoring. So the system would tell us when the patient needed to be seen, so exception-based care. This reduced the volume of patients we had to see, but at the same time, it filtered the ones that we had to see. So this was an advantage, a lesson that we learned from the pandemic. But one of the issues is that when you have this, the alert volume can be very high. So there's a lot of invisible work that is conducted, remote management, which is non-actionable, and only a fraction of those evaluations lead to an in-person encounter, which is important, but there's a lot of undeserved work, non-actionable work from the clinic's point of view. So what are the options? So continue with remote monitoring, but filter that information, particularly with analytics or artificial intelligence. So those relevant data come to the clinic. And that means that actionable events can be acted on promptly to look at-risk patients, and this reduces the load of non-actionable work that is conducted by the clinic. This is exceptionally important for ILRs. Implantable loop monitors are implanted very frequently. The volume is increasing, projected to increase even further, and they lead to a large number of alerts, many of which are false positives. So this is the problem that we are confronting just now, and during this session we will learn about methods that we can use in order to tackle this further. So the QR code will come up again if you'd like to scan that. But in this interim, I would like to introduce Dr. Suneet Mittal, who has a long history of interest in remote monitoring.
Can I have you take that chair so I'm not standing in front of you?
No, that's fine.
I'm going to stand, yeah.
Yeah, okay. So Dr. Suneet Mittal, Director of Electrophysiology at the Arrhythmia Institute at the Valley Hospital, and an affiliate of the Cleveland Clinic. Welcome, Suneet.
Niraj, thank you very much, and thank you, Arnaud and Implicity, for sponsoring a talk on what we, of course, think is a very important topic in the field of electrophysiology, and that is bringing remote monitoring to essentially all patients. And today I've been tasked with addressing this issue of remote monitoring as standard of care. What are our current constraints as well as challenges? So although you look around the exhibit booth today and you see a number of companies in the remote monitoring space, I think it's always important to note that remote monitoring is not a new concept to cardiologists. And I would argue that trans-telephonic monitoring, released in the 70s, was probably the earliest form of remote monitoring used in our specialty. We all are familiar with the crude information that emanated from these systems, and yet for decades we followed patients' implantable devices to ascertain their battery status, their underlying rhythm, and get some information about the sensing and capture of these devices. The field was really dormant for over 30 to 35 years, till about 2002, when we had the ability to replace in-office checks with home monitoring using an inductive or wanded-based system. And for the first time now, we could get more precise information about battery, better resolution idea about rhythm, sensing, and capture. But importantly, for the first time, we had access to the diagnostic information stored in these devices. The next inflection point occurred a few years later with the release of fully wireless devices, which then introduced additional sensors, giving us information about patients who may be at risk for developing heart failure exacerbations. And as Niraj very much appropriately pointed out, about 10 years ago, the development of the implantable loop recorder capable of daily automated ECG and data transmission really changed the way we think about things. Now, when we think about remote monitoring, I like to think about the 5 things that are really supportive of remote monitoring. The first I'll say is reimbursement. Of course, reimbursement varies from country to country. For the purposes of this discussion, I think we should at least acknowledge in the United States, there's a very favorable landscape for remote monitoring reimbursement. In fact, these visits are reimbursed at the same level as an in-office visit, so reimbursement should certainly not be a barrier to moving things forward. The second is that there are guideline documents, such as the 2015 Heart Rhythm Expert Consensus Statement document, and this was a document that really was spearheaded by Dr. Varma and Dr. Slotweiner, and really established for the first time this important concept, that all patients with an implantable device should be offered remote monitoring as part of the standard follow-up management strategy. Class 1 recommendation, level of evidence A, the highest level of recommendation. I should also add for the audience that finally these guidelines are being in the process of being revised, and hopefully in 2023 we will have a more updated document about this issue. But what will not change in that updated document is this notion of moving away from a calendar-based schedule of device follow-up to one that is alert-based, limiting visits in the office to an annual, or even based on some recent studies that emanate from Japan, to an every 2-year process. And the idea is that the device is good unless you're notified for things such as atrial or ventricular arrhythmias, something that may suggest an integrity issue with the device or leads, and heart failure issue, and otherwise you basically can follow patients remotely without having to bring them to the office. And work that Dr. Varma and colleagues have done have really established the safety in a pretty unequivocal manner of such an approach. The third issue is the scientific data. Now, time precludes me to go into all the scientific data that supports remote monitoring, but I do want to center the fact that over time, the value proposition of remote monitoring has been centered around these issues. Understanding device-related issues, not only battery issues, but whether there's a malfunction within the generator, important lead-related issues, both from an integrity standpoint, but also when patients are pacing the RV when you don't want, or not pacing the LV when you want them to be pacing. Of course, important information about atrial arrhythmias, the burden of atrial arrhythmias, which we're starting to understand to be a very important marker for outcomes, information about both non-sustained and sustained ventricular arrhythmias, and of course a slew of work going into trying to understand heart failure status in these individuals to keep them out of the hospital. Now, I want to just highlight one study that I had the privilege of working with Dr. Varma on, which I think still represents an important advance in the field, which is trying to understand the association between adherence and enrollment in remote monitoring and patient outcome. So this is a study that we did several years ago, where we took a very large cohort of over 250,000 patients implanted with a pacemaker or defibrillator capable of wireless remote monitoring. And we followed these patients to determine if they were enrolled in remote monitoring, if so, how compliant were they with remote monitoring, and what impact did that have on their overall survival. So the first thing we saw was, disappointingly, more than half of patients were never enrolled in remote monitoring, even though they had a system fully capable of being remotely monitored. In the nearly half the patients who were in remote monitoring, only about half the patients were highly adherent to remote monitoring, whereas the others were enrolled but not using it to a very high level. When we look at these 4-year survival curves of patients, shown in green are the patients who were enrolled and highly adherent to remote monitoring. These patients had twice the survival over time as compared to the patients shown in red who never enrolled in remote monitoring. And shown in blue is an intermediate effect of patients who were enrolled but were not highly adherent. They certainly did better than the ones never enrolled, but clearly not as good as the patients who are highly adherent. And outside of this study, there have been many studies also supporting the role of remote monitoring for healthcare utilization and other surrogates of improved outcomes. And here's just one such study that highlights that. And in this study, what we were able to demonstrate was that use of remote monitoring was associated with a 30% reduction in hospitalization cost over time. Now, just a few words about heart failure. While this is far from being perfected, there have been a number of approaches that companies have taken. Here's one approach of using multi-parametric sensors to try to predict heart failure exacerbations with a reasonable sensitivity and specificity, giving us about a month's leeway into predicting heart failure hospitalization. Here's another approach that really focuses on trying to ensure the adequacy of left ventricular capture by essentially looking at the relationship of the electrogram from the LV to RV and following some very basic principles. And what we've been able to learn is some approaches like that can really identify patients outside of just pacing LV percentage who may not be doing well from remote monitoring. Now, the fourth area where there's been a tremendous investment in is both hardware and software capabilities. I want to just highlight one word about smartphones and one word about artificial intelligence. One of the challenges with remote monitoring is this poor connectivity. US-based systems have historically relied on bedside communicators to help transmit the data from the patient's device onto central servers, which we can then access as clinical providers. Thankfully, this new approach utilizing the smartphone as the transmitter of data between the patient and us, I believe is really facilitating the reliable transmission of data, and I suspect will become the new normal universally over time. But despite this, we continue to have a number of workflow challenges because of how complicated remote monitoring is. Shown on the left are all the tasks that must be done to employ remote monitoring appropriately. Shown in the middle are the limited number of healthcare professionals who've historically been relied on to do this task. And what you should see from what you see in the exhibit hall today is really a recognition over time that this may really not be doable in the context of your own processes, and there may be the need to use vendors such as Implicity and others to really help facilitate this process. Besides just the labor that can be provided, these external forces can also allow us to take advantage of strong innovations in artificial intelligence. Why is this important? Well, let's just look at one type of device that we deal with on an increasing basis, the implantable loop recorder. Here's a study we did looking at the positive predictive value of a loop recorder detected AF episode as a function of the duration of AF episode and the population for which the loop recorder was implanted. What you see is that when AF episodes last greater than an hour, the positive predictive value is very, very high. But as the episodes become shorter, the positive predictive value drops, and anyone who takes care of these patients knows this because you've all had to adjudicate false positive episodes, often emanating because of atrial or ventricular ectopy, sinus arrhythmia, or over-detection of noise. Artificial intelligence does seem to be the area. Many companies, including Implicity, have worked on novel AI algorithms. You'll hear some about that later today. And it does appear that use of this type of approach can help us filter out maybe 2/3 of all the garbage that we normally are asked to adjudicate. And this increased efficiency may translate into greater enthusiasm for universal use of remote monitoring in our patients. Finally, I'd be remiss if we didn't acknowledge the fact that there's still work to be done. Cybersecurity is a big issue with completely wireless systems that must be addressed and will be an impediment otherwise to getting into an area where not only do we have remote monitoring, but we have full remote programming of all available devices. And I'll just end by saying that for those of you who are interested in continuing this conversation, do think about attending HRS's inaugural meeting, HRX, where a significant amount of the meeting will be devoted to really understanding remote monitoring and all the solutions that are both needed and currently under development. And this will be held in a couple of months in San Diego. With that, I'm going to stop and turn it back to you, Niraj.
Thank you very much, Suneet.
You can just do that. Okay. I think so. Sorry.
Thank you very much, Suneet. So that's a tremendously comprehensive overview of the current state of affairs. So what we've learned is remote monitoring is standard of care, but there are issues with patient adherence, but also clinic adherence. This is very, very difficult to execute. And there's an increasing importance attached to third-party platforms that would help us facilitate management, and also AI mechanisms that can be enabled within those platforms. So I will review this. So loop monitors lead to long-term monitoring up to 3 years, indications cardiac arrhythmias and cryptogenic stroke and syncope. As I mentioned earlier, amongst implantable devices, these are increasing in volume in terms of implants, and they generate a huge number of alerts, to the point where the Cleveland Clinic has outsourced their loop monitor management to a third-party platform. And we haven't done that for any other device. So this is the straw that's broken the camel's back. Remote monitoring is supposed to ease workflow and provide early arrhythmia detection, but it has to be enabled and has to be monitored. Loop monitors generate high alert burden, which are distracting, and as has been mentioned before, a high false positive rate. How high? So this is a study conducted by our colleague Prash Sanders, and they analyzed alerts arriving in a remote monitoring database. They were pre-categorized as asystole, bradycardia, and atrial tachycardia and fibrillation, so typical. They were adjudicated using the rhythm strip as either true positive or false positive. The results: over 14,000 alerts were transmitted from 1,470 patients over 6 months, a median of 6 alerts per patient year. In comparison, ICDs may only generate 1, maximum 2 per patient year. So this is automatically a 3 or 4-fold increase in volume. Not surprisingly, atrial tachycardia and fibrillation accounted for the most, almost 50%, asystole, tachycardia, and then patient-activated episodes. The false positive rate after adjudication, asystole, 76.8% false positives. AT and AF alerts, more than 74% false positives. Better for bradycardia and asystole. But this is a huge volume of false positives. So altogether, 60% of all alerts were erroneous, and these were not concentrated in a small group of patients or a small group of devices. This was across the entire ILR community. So all ILRs that are implanted are equally guilty in this. So what are the solutions? AI solutions. We've heard a lot about AI. Traditionally, ILR-based diagnosis is based on the RR interval, but there's a huge amount of data that is contained in an ECG strip. So we can look at the RR interval, we can look at the segments, we can look at the isoelectric intervals, the signal content which is hidden to the naked eye, but can be visible to computer mechanisms. Of course, these have to be trained. There's input in orange there, training sets have to be used, but deep learning networks can set the logic and produce a result or an output. And this refers to Dr. Mittal's data using AI mechanisms to look at atrial fibrillation alerts, reduced the number of false positives. So with ILRs, the positive predictive value significantly increased when using the deep neural network filter, from 53.9% to 74.5%. So what else can we do? So let's look at an ILR ECG analyzer here. And on the left-hand side, what you see is the manufacturer management. So this is the ILR, the ECG recording that is transmitted, and the manufacturer platform analyzes it. And as we've heard, as we've learned, there's a high incidence of false positives. Implicity is a third-party platform, then acts on those data. So the Implicity platform uses those data, sends them to the ILR ECG analyzer. So this is a software, is a medical device designed to solve the problem of false positives of the ILRs outside the ILR. This is a novel algorithm based on a proprietary AI training method. The training itself is based on an annotated database of ICM episodes collected via the Implicity remote monitoring platform. This is FDA approved and CE marked. Following that analysis, those data are returned to the Implicity platform and then available for website review on the right-hand side. So this is the interface that we will be testing. Here's an example. This is a little busy here on this projection, but you see the original manufacturer classification right at the top, then the diagnostic status and source that's available, and then the action of the ILR ECG analyzer. So reviewing an episode with an electrogram is possible, and this is using the IM007 AI mechanism. There is manual override if required, and then there's a final classification. There are quick filters associated with electrogram review that can also be used. Here are two examples. So machine learning, as I mentioned, sees all of the signal, not just parts of it. So on the top is VT, because of T-wave oversensing, the diagnosis of VT reclassified as normal using this analyzer automatically. In the bottom, PVC activity by Gemini, bradycardia reclassified as normal using the AI mechanism. So the study objectives that we had was to evaluate a novel AI-based algorithm that reclassifies arrhythmias in ILR ECG strips, measure its ability to decrease the false positive rate when compared to the Reveal Link platform itself, while maintaining a high sensitivity. So this is study number 1 of 3 that I will report. This was presented at HRS last year and currently in manuscript form for submission. So Medtronic Reveal links were followed on the Implicity platforms at 31 European and US sites, a total of 455 patients. Patient-triggered and non-interpretable artifact in ECGs were excluded from this analysis. The number of abnormal events as defined by the implantable cardiac monitor was 695. Artifacts were again excluded. Analysis was performed by two separate methods. One was an adjudication committee of experienced electrophysiologists on the left. On the right was a function of the AI algorithm. So on the left, out of those 695, 219 were deemed false positives. 416, 60% were true positives. In comparison, our AI algorithm reclassified out of those 219 false positives, 174 as false positives. So this was a 79% success rate versus an experienced adjudication committee. So excellent performance from the algorithm, first iteration of this algorithm. On the bottom, regarding true positives, you see 413 of 416 were correctly identified. So we did not lose any false positives here, any true positive data here. The three cases that were missed were largely due to atrial tachycardia and not due to any significant or dangerous arrhythmias. So as a result, for AT and AF, this is the breakdown, sensitivity was 99% and specificity 82%. Asystole, bradycardia, or VT, 100% sensitivity, specificity above 98.5%. So excellent performance. So in conclusion for that study, we would say that the ECG analyzer algorithm reduced the Reveal link classified false positive episodes by 79%, which potentially reduces a great deal of analysis burden from the device clinic, 80% reduction, while at the same time maintaining a high sensitivity for abnormal ECG strips, therefore preserving patient safety. Moving on to study 2. This is the number of ILR episodes that need review. So we measured the proportions of episodes reclassified as normal rhythm, that is identified as false positive, by the algorithm. This was conducted at 20 EU centers. This work was presented at the ESC last year. 370 ILR patients. Each ILR transmitted episode with an ECG was collected, and the algorithm reclassified it, applying the same labels as the ILR, that is asystole, bradycardia, ATAF, VT, and artifact, and adding normal rhythm. So again, same structure, 20 centers, 370 patients, ICM defined as abnormal, 2,821. Algorithm defined as normal, 1,227. So as a result, AI reclassifications resulted in a 43% conversion of abnormal episodes to normal episodes. And if we look at the excluded data from this analysis, those are patient-triggered episodes and those with no transmitted ECG, this represents 33% of all episodes being reclassified. So conclusion from this study, the novel AI algorithm significantly reduces the quantity of episodes flagged as abnormal and typically reviewed by healthcare professionals. So this has the potential to reduce the workflow burden associated with false positive reviews. Now, one of the benefits of automatic remote monitoring that Dr. Mittal emphasized was early detection of abnormalities. Early detection of significant events leads to improved patient outcomes. So applying this AI algorithm, this further analysis should not in any way interfere with that early detection capability. So this was an analysis of time to first event detection. So amongst 20 centers, all remotely monitored, that were enrolled during the second semester of 2020, an analysis was conducted of all ILR transmitted ATAF episodes and reclassified using the AI algorithm. The time between implantation and the first confirmed ATAF episode was measured and compared without and with AI using a non-inferiority test design. As you can see, in gray, without AI, on the right, in green, with AI, absolutely no difference in time to first detection. So using this analysis platform does not in any way interfere with early detection capability of our remote monitoring device. So this reclassified, again, 34% of all ATAF reported episodes, no adverse impact on time to detection of first validated ATAF episode. So in conclusion, I would summarize and say that the ILR ECG analyzer algorithm by Implicity reduces reveal link false positive episodes by 79% while maintaining a sensitivity of 99.3%. The novel AI algorithm significantly reduces by 1/3 the quantity of episodes flagged as abnormal and typically reviewed by healthcare professionals, which has significant ramifications for FTEs in the device clinic. This novel remote monitoring AI-based algorithm was able to reclassify 34.4% of all episodes with no adverse impact on time to detection of first validated ATAF episode. So this is the first version of an AI algorithm applied to reveal linked devices and showed significant success with significant ramifications for clinic workflow and ability to adhere from both the clinic point of view and the patient point of view to a remote monitoring program. Thank you very much.
Thanks a lot. I'm privileged to be in such good company today. And so I'm Arnaud Rosier. I'm a founder of Implicity, so everything I said should be taken with great, care. But outside that, I would love to share a few thoughts with you about how we can actually maybe transform remote monitoring burden into some kind of opportunity, one of which being research, obviously, and maybe others. So we had a lot of these pictures, from manufacturers, and I like this because, remote monitoring is so good that our patient can basically sleep daily, like in plain sunlight, and they seem very good, everything is a dream. And then we know this dream is kind of mandatory for us now. I mean, we are pretty much supposed to, thanks to you guys, we know it. We are supposed to deliver this standard of care for patients. This is our mission. And then the question is, to what extent do we feel like it's such a dream for us, healthcare professionals? Digital health is supposed to be amazing. Digital is what we see now with smartphones, and it's supposed to be super easy to use. But we have pretty much experienced, and we all had firsthand experience how much hard it is to cope with remote monitoring. And I don't know a lot of people that love remote monitoring. Even if we work on it, I'm not sure we're really liking it. But, we still need to do something. And, it's kind of the same when I was a resident. Everyone always spoke about having this universal programmer that we never got. And I want to share the vision that maybe remote monitoring is a place where something is changing about data. And that is that for the first time, maybe, because everything is digitalized, because data comes through manufacturers' platform, third parties like Implicity can emerge and can, try to cope with this data instead of what we have to do manually, and maybe can bring some kind of revolution or evolution in the field for healthcare professionals. So it may be something that we can do. And that's actually what the vision that started Implicity. I tried to solve my own problem. Many physicians are entrepreneurs that basically started by, trying to solve their own problems. And that's what we did within Implicity. It took years and it took tremendous efforts to get access to discrete data from manufacturers' platform. But that changes everything, because when you have discrete data, you can actually harmonize it and apply different kind of techniques and artificial intelligence to make the job of healthcare professional, whether it is physician, nurses, medical assistants, clinical assistants, better, because it's going to be easier to actually do remote monitoring. And taking one step back, our mission, I think, as healthcare professionals, EP or, EP team, is probably first to deliver the best care to our patients, obviously, and that means we have to organize to do that, but also, especially now post-COVID, we probably have to find ways to bring the resource to keep the clinic alive. And, Suneet mentioned the reimbursement, and, it is something we need to do. It's not like we crave doing it, but it needs to be done. And at the same time, part of our mission is to bring new evidence so that we actually deliver the best care. So these are two folds of the same medal, I think, of our mission as healthcare professionals. And that, what does that actually mean for remote monitoring? I think that means we need to have the best tools to do this job. So first thing, we need to be able, to have our teams spend the least time possible to handle all the non-clinical work, which means, reporting, doing the reports, doing the billing, but we still need to capture the billing. And something completely amazing, while, reimbursement is pretty good in the US, the average capability from teams to capture reimbursement is often something like 10 or maybe 20%. So that means a lot of money is left on the table that could be used to better, to hire more staff, to better organize, and to basically have more resource doing our job. So this is still an issue for most centers. And then we need also to, basically do the clinical stuff, the routine care well. And we are all using right now so much tools, so many tools, like 4 platforms. Most centers use PaceArt, or most large centers at least. And then you have your EHR, and then you have the billing system, the reporting system, and sometimes you want to do research. You need to, have some kind of residents entering data by hand or whatever you want to do. It's crazy. And if you want to do research or AI, you need to capture data, but you don't need to capture just PDF parts. You need to have discrete data so it can flow, and you can actually use these kind of techniques. So my point here is really to say, what kind of thing do we think we need to actually do remote monitoring the way it should be done? I think, I'm pretty much biased on that, but I really think we need to have one tool, like one good tool, at least. And that's basically the tool that PaceArt was supposed to be, but, I don't know many people that think it's going to be, so let's try to find other things now. And I'm pretty sure it's going to be one platform, one third party, whether it's Simplicity or someone else. One third party, cloud-based universal platform that gets everything in one place. And it has to be very, very easy to do billing and report automation, because if you don't automate to some degree, then you're going to lose a lot of time. And you want to do routine care, and you want to do routine care with just one tool if you can do it. And you want to capture data as you're doing routine care with just one workflow, basically. So workflow is super important. And if you don't get a platform that is using discrete data, but instead is using PDF parts, like most, you're not going to be able to apply algorithms on it. You're not going to be able to pre-fill whatever report that is, whatever research database you want to use. So you're not going to be able to leverage the data that is accessible from the device. And that is especially important, of course, when you're doing research, because that's where remote monitoring is such an opportunity. You've seen these studies they did about 250K patients. This is feasible because it's digitalized data flowing in. And this can be leveraged for any research, mostly on devices, of course. So the platform that we designed originally at Implicity was really made as one single tool to handle not only the reporting part, the billing, but also the clinical part, but also the research capabilities that you can have doing that. So I'm speaking about data, So what are we able to collect, right? So obviously you're aware of what data can be gathered by remote monitoring, a lot of it. I mean, it's not everything on the device side. It's going to be more and more evolved over time. But these are just pieces that we collect daily at Implicity across tens of thousands of patients. So this is just a simple graph to show you that we can harmonize. We don't have to stick with each manufacturer, each device, each patient data. We can just collect the data points. And then we are going to reorganize and reharmonize the data and just show it to you or show it to your research team in a way that it should be, right? I mean, it's pretty straightforward. You can do it for zone settings. You can do it to have all the lists of episodes and, of course, duration, types, heart rate. But you can also, to some degree, for some manufacturers, and it's going to evolve, and be for most devices, you can get actual discrete data from EGM. So that means this can be not only reprocessed through AI, but you can actually study them and develop new algorithms. You can even partner with us or others to develop algorithms that are going to ease our burdens. But you could also analyze a lot of signals here to try to make sense of this data for not only reading it manually, but doing automation and making science go forward. This is just a sense of what we could get. I mean, I'm not even sure we have this in programmers, like such density of daily measures. And this is totally, I'm pretty sure this is a Boston, just a private joke because of the sensing, moving quite a bit. So it's probably a Boston ICD, I guess. But this is just to give you the idea of how much data we can collect per patient. And everything is gathered automatically, can be pushed back in a research database. So this is, just more example, atrial burden, heart rate. And this is about physiologic parameters. Not only now we are checking devices, I think now with remote monitoring we are at the point where we are checking patients and physiologic parameters. So this is for heart failure, obviously, but each device collects around 200 different data points daily per patient as a mean. And to end, just two examples about what can be done on the research side when you have so many data automatically gathered daily. So you can do two things basically. One is retrospective studies, and one is prospective studies. This one is just a very simple, it's not the best study, but it was done in weeks. That's a retrospective study that we did when COVID started early 2020. And basically, we collected all episodes of arrhythmias, atrial and ventricular, across thousands of patients. And it was very easy to reuse this data to just have a sense of whether it was evolving, whether the heart rate, the activity level of patient was changing, was there more VT or more AF or whatever, But the idea here is really that we didn't have to spend so much time gathering the data. We just had to analyze it and publish. And it was so much a relief to do that. And so that's one example. One other example that we are doing right now in Europe, so this is a French consortium, and they came to us and said, okay, we want to use what you're doing with remote monitoring, not only for clinical daily care, but we want to use it for our research. And we would like to put in place a large prospective cohort of all our patients with ICD. So that's basically every new patient with a first-time ICD, could be an upgrade. And we want to continuously remotely follow this patient for research to be able to have a very, very large data set we can use for research. And from this data set, we're going to maybe answer different questions and subsets of sub-studies we're going to do. But basically, everything is collected automatically through Implicity platform, and we are just pushing to these guys all the data that we collect within their centers. So we enrolled 4,000 patients over 3 years. So I'm pretty sure in the US could be 40,000, to be honest, if we had like the 21st centers in the US. But this is pretty much unbiased because this is every consecutive patient on all these centers. So this allows to have a lot of perspective of new studies that we could do using remote monitoring as a way to not only get the burden of the noise and the all the information we don't want to see, but just transfer them into discrete data, and then reuse them for research and knowledge generation. So I think that's pretty much the idea here. Sometimes we have to collect additional information, of course, clinically, and then we have a very easy eCRF that we had to add, but it's one click away, and you can just, for the enrollment of patients, add a few key information. So that's really what digital should be for us healthcare professionals. Is our work daily, because that's not always the way it is. And I would love that it would be the same for every product. So my point is really to say, okay, we've been in remote monitoring, depending which center, for probably more than 20 years now. 15, 20 years. It's still pretty much a very high burden, if not for physicians, at least for our teams, our device management teams. I think this is the time where we can begin to try to understand what are the new tools and how can they be leveraged. And artificial intelligence is definitely going to be something we're going to not only speak about, but see and use daily. And we have now, we have seen the Medtronic algorithm, there is the implicity algorithm, a few cardiolog's algorithm, of course. So a few companies already developed algorithms that work and that we can use and are FDA evaluated. So I think this is super important to understand, but also to understand that in order to achieve that, you will need to use some kind of platform that leverage discrete data. If you just stick to PDF parts, you're going to stick with manual review of data forever. And I think that's a very important point. And so we can focus on our mission and maybe doing education of patients and speaking with patients more and not just reviewing data at the hospital. Just a very quick note about the fact that implicitly we are promoting a contest for research, which is basically we are going to give away the platforms for people that are selected by the best gentleman here, and by Jackson about ideas they have on how they could use implicity. They're basically their patients' data, not implicity, but it's just a tool to answer new questions. It's completely free of charge for the free first eligible selected projects. You can apply. It's like 5-minute form to apply. So do it while speak with people about it. But it can be an opportunity to just try it easier without the charge of having to convince everyone in your clinic. And I'd be happy to speak. Just meet on the booth if you have a chance to come by. Thanks a lot.
Thank you, Arnaud. And just as a note, the first time I interacted with Arnaud was not in person. I reviewed one of his papers about 10 years ago. It was a visionary paper. At the time, we were just excited about the ability to have automatic remote monitoring. But this paper was part of your PhD thesis?
Yeah, it is.
Yeah. Was visionary. It talked about getting the remote monitoring data, a platform, applying artificial intelligence, interfacing it with an electronic medical record. So way ahead of its time. So remarkable paper. And now I'm very, very happy to see that you have translated that into a product that we can use. So wonderful
That's
vision,
very
Arnaud. Wonderful vision. So we've learned that this platform, the Implicity platform, can help us with current problems in remote monitoring, adherence of patients, adherence of clinics, streamlining the data inputs, and applying AI mechanisms to improve patient outcomes. It's an ongoing project, but this is moving in the right direction. So very, very impressive data. But I have a question from the audience, and please feel free. We have some time to scan the QR code and proceed with submitting other questions. This one is directed to you, Suneet. So what is the utility to yearly follow-ups of ILRs implanted for syncope and cryptogenic stroke? Do you think we will move towards alert-based only in-office follow-up for these patients?
So I think that there is, I think from the technology standpoint, I think you could probably follow a patient completely remotely for the entire 5 years. I think from a doctor-patient relationship, I think it's important that there be some minimum follow-up just to make sure that things besides the rhythm is being looked at, are there the optimal medications or risk factors being controlled? And you have to have a uniform pattern to do that. In our practice, because patients can easily fall through the cracks, we've taken the responsibility of ensuring a once annual follow-up. If the world was perfect and the patients were being seen by another provider, I think an electrophysiologist could easily manage those patients remotely. When you think about more sophisticated devices, pacemakers, defibrillators, CRT, I still think there's a value in the wound check in making sure that everything is looking okay. Now, that can certainly be done using photo and some tools that are being done, but I do think that there's other aspects to device care other than just what's stored within the device itself.
Yeah, thank you, Suneet. I agree. I think when we say alert-based care, at no stage are we suggesting that we abandon the doctor-patient relationship. We do not want to abandon the patients. But what we can say is that from the device point of view, the patient may not need to be seen if you have continuous remote monitoring, which is active. You have to have assured connectivity to practice alert-based care. And then some patients with a very low comorbidity burden, for instance, those with pacemakers, and pacemakers are therapeutic. ILRs are diagnostic devices, so patients do need to be seen. Diagnoses can change. We don't know the diagnosis in many ILR patients. We're trying to find out. But say in a bradycardia patient who's been treated with a pacemaker, that's the therapeutic device. They have no comorbidities apart from hypertension. I am happy, following the Japan at Home study that you had mentioned, to not see the patient formally in my clinic every 2 or 3 years, so long as they have continued primary care relationships. On the other,
Can I add a point to that? I wish the system was so perfect. What we find is that even if we wanted to have someone just on alert-based care, patients engage with the healthcare system so frequently in those 1 or 2 years, and there are so many opportunities for them to undergo a device check that they inevitably wind up undergoing checks they don't need. At least at our hospital, if you come to the emergency room with any issue and you have a device, you're going to leave with a device interrogation because that just goes with the presentation. And so these patients could be followed perfectly well, but it's more than what we want to do. It's really changing well-indoctrinated systems of practice.
That's well said. And perhaps emergency rooms should be encouraged to log on into the Implicity platform and get a very up-to-date interrogation. Further questions, please. So let me ask Arnaud one. So we hear a lot about AI. AI is being used everywhere. What is specific, what is special about the neural network that you use?
About
the AI mechanism that you have employed.
Okay.
Can you describe it to us, please?
Yeah, sure. So, as you said, we hear a lot about AI, right? So usually when we hear a lot about AI right now is because of machine learning and to some degree deep learning. So basically, automatic learning from the algorithms based on a large amount of data that are well annotated or recognized. I think the reason why we are seeing this right now is twofold. One is because we have these techniques and we have data that is digitalized. So we are seeing now a few companies working on that. But also because, on the regulation side is being matured, and FDA has done a really great job at having a very clear doctrine about how you can, not only build AI, but evaluate it. So what is unique in what we can do within Implicity was the fact that we haven't just, got the usual HL7 file that manufacturers kind of push to EHR to some degree. We knew we wanted to build AI because we thought it was important to have all the data as we have in programmers. And so we developed a way to get access to data more in depth and more in a discrete way. So we were able to feed our data science team or our partners team, in different academic centers with more precise data. But when it comes to what we developed, I would say it's pretty much standard techniques. So it's nothing that most companies couldn't, and it's probably pretty close to Medtronic. developed for their own devices. But I think we're going to see more and more third-party algorithms. I hope so. And I hope it's going to push the innovation within large companies as well. Maybe last comment is I think we can probably develop now new things that are more complex. In heart failure, for instance, I think it's a great place to develop. I mean, no one knows how to manage heart failure really and how to understand how it works. But I get heart failure prediction and therapeutics or drugs optimization is probably a key thing we have to interest for our patients outside device pure like daily management.
Yeah, so preempting heart failure admissions has been the holy grail of remote monitoring. And many, many signals have been tried, thoracic impedance, patient activity. None have been very accurate in predicting heart failure. So maybe AI-based mechanisms would help us here. But do you think there are data that should be integrated with whatever device can transmit, for instance, with wearables or with the electronic medical record? Do you have a method of accessing EMR data?
Yeah, so actually, I started working on EMR data because this is where we have the most data, right? So in theory, EMR, EHR is where you want to collect data. There have been a fairly, nice attempts and successes in terms of natural language processing of discharge summaries from physicians. But what we have seen successful the most right now are still mostly digitalized sources of data. And that's why, such as imaging, we have a lot of AI companies working on imaging. ECG, cardiologs was a great example, and with Suneet Mittal, they worked on ECG with, basically they proved me as a bad EP because I understood that I couldn't do better than AI at some point. So, and I was happy to see that, but still, it's a one to my pride. And then I think the reason why we see AI now on devices is also because this is digitalized. So maybe it's not a very, very good reason, but I think we're still continue to see more AI based on discrete, structured, digitalized data before we see a lot of things on the EHR side.
Thank you, excellent progress. One final question to wrap up with, just popped up. If we move to alert-based follow-up, will we lose a significant amount of billing? What are your thoughts?
Significant amount of?
Billing. Is there a revenue loss associated with going to alert-based care?
Look, I think that when you look at the US model, which is, I think, what we can comment on, you're still being reimbursed, at that quarterly or monthly for pacemakers, defibrillators, and ILRs respectively. So that's going to be there. And the alert care is reimbursed separately because if you have to evaluate the patient, that would be on some sort of an E&M billing type of code. So I really am not concerned about that issue. At least in the US, I think we have well-established mechanisms to do this and think only about outcomes and not think about any kind of a financial loss.
Yeah, I can comment on that. I completely agree with what you just said, and I think it applies outside the US as well. When you have reimbursement, which is not always. Meaning, you can totally do clinically relevant, alert-based remote monitoring of patients while, providing what is needed to, have the payer understand that you did your job and you did your 3 month or your 30 days reports, etc. I think what is better in the US is that you get reporting, but what is worst in the US is you spend your time doing normal reports that has no clinical value. And I think that you can do both at the same, you can do clinically relevant, eventful, review, and at the same time have some piece of software, populating normal reports and don't spend your time on this. And I think it's relevant. This is what we do when billing doesn't get in the middle of what we do. So this is the way we design the platform, to basically do both for what it is. One is billing, one is our work and our mission.
Bill for our actionable work, but really what we want to do is reduce the huge volume of non-actionable, meaningless work that we have to conduct in our current environment. So this really is the future. So thank you very much, everybody. Thank you to the panelists. I do appreciate it. Wonderful, wonderful session. Thank you.
Thanks.